and clinical risks in hospital-based gynaecology and maternity services in Liverpool. We are in the very first stage with the development of the case for change, which sets out evidence about the challenges and the main reasons for change. It's important to note that at this point we are not providing proposals or solutions and no decisions have been made. We recognise the historical significance of Liverpool Women's and the love the people of Liverpool have for the hospital. We recognise the historical significance of Liverpool Women's and the love the people have. We also recognise the amazing work that the staff do every day to ensure this is a safe place for women and their babies, and this is a priority for us. It needs to go back. So by way of introduction, firstly, today's discussion will use the term woman and women and women's health, but it's not only the people who identify as women who use women's health services. Trans men and non-binary individuals assigned female at birth also access these services. And in terms of people using these services, on the slide behind me, you'll see that each year nearly 30,000 procedures performed and around 7,500 new babies are brought into the world. And these services are a crucial part of our local NHS. We have the most dedicated staff, including doctors, nurses and midwives, and we know that these staff are passionate about the care that they provide. Liverpool Women's Hospital is more than bricks and mortar. It's the dedicated staff and the brilliant services it delivers for people, and has been on a journey. In a relatively short period of time, it has had 3 different locations, with the latest on Crown Street being opened by Princess Diana in 1995. However, there are challenges, and to put this into context, in recent years, these services have been the focus of national policy and following several independent investigations, with the most recent policy for maternity care as set out in the 3-year delivery plan, focused on 4 key areas, and we must ensure that we are meeting these requirements. And more locally, in 2023, the Liverpool Women's was inspected by the Care Quality Commission. This assessment looked at what was being done well and where improvements are needed. And the outcome was an overall rating of requires improvement, and a programme of work was progressed to address this, including work to improve the Crown Street site. But there are also examples of positive feedback. The gynaecology services received an overall rating of good. The report also specifically highlighted how staff at Crown Street had a clear focus on the needs of people and how they strive to deliver best possible care. And in terms of Crown Street, the NHS is wholly committed for continuing to provide services from there. Crown Street is a vital part of our local health system and will not be closing. We have recently invested in the site with £5 million to establish a centre for gynaecology procedures. We're really pleased that this will open from spring 2025. And in addition, Crown Street now hosts a community diagnostic centre which has delivered improved access for scans and tests. Whilst this is really good news in supporting the delivery of quality and safe services, there remains to be challenges that we need to address. You'll hear more about this and the programme as I hand over to Fiona and Lynn. But finally, it's important to note that at this point, no decisions have been made. We want to continue to listen and engage with you. And subject to the board's agreement today, we'll be embarking on a wide-scale programme of engagement, and we'll continue to work with our partners, stakeholders and members of the public. So I'll hand over to Fiona. Thank you.
We're actually going to start by hearing from one of the clinicians who delivers care for patients at Liverpool Women's Hospital. So thank you, whoever's going to make the video play.
My name's Rachel McFarland. I am a consultant obstetrician at the Liverpool Women's Hospital. I've recently taken up the post as the Associate Medical Director for Patient Safety and Quality. And prior to that, I have spent a number of years as the Maternity Safety Lead, which is where I've probably done most of my work here at the Women's. I look after most patients who are pregnant, and within that they have pre-existing medical conditions, and that means that they've been looked after possibly by doctors who don't work here at the Trust, and then when they become pregnant we have to work with those doctors as well. So there is a lot of working between the different trusts in the region, and those working relationships are great, but it can put a strain on the way we work, and we have to think about ways that we work differently. We also know that things don't always go well in a patient's journey, and therefore sometimes we need some of those critical care services which are not based here. And for the patients that need critical care, they would have to go to another hospital, such as the Royal Liverpool or Aintree Hospital. And it's not ideal for the patient or the family to start their journey in one place and then have to be transferred to another hospital. One that always comes back to me is a patient who her closest hospital would have been Aintree, but she came and booked her pregnancy here at the Women's, and she had what lots of pregnant women have in the early stage of pregnancy, lots of nausea and vomiting, which meant that she had to come into hospital, which isn't an ideal if you've got to travel to this hospital. She then got admitted to Aintree, and unfortunately there were complications with her nausea and vomiting, but it meant that we as the obstetricians would go and see her in Aintree to make sure that she had some continuity of care. The complications that she had meant that she was put on a medication that made her more likely to bleed, and at around 32 weeks pregnant she developed a really severe nosebleed. The specialist services for nosebleeds are based at Aintree, so that's where she went. Our community midwifery team will go and see our pregnant patients who are in other hospitals, which they did, and they identified at that stage that it would probably be better if she was at the Liverpool Women's because she was going to need delivery. So she came to us. She was part way through her treatment with the ENT doctors. We were able to deliver her, but we then required the ENT doctors to come over to the Women's Hospital to continue that treatment that she needed for the bleeding that she'd had from her nose. Because of the haematologist service, which is then based at the Royal, we had to link in with another hospital to continue her care. And there were complications from the surgery that she had to deliver her baby, which required her to go back to theatre. And we can deal with lots of those things here at the Women's Hospital, but again, some of those expertise are based at the Royal. So we were able to get the surgeons from the Royal over to look after her and to help us with that surgery. Her baby at this stage was born preterm, so we have a very good neonatal unit, and so the baby was being looked after in the neonatal unit. This patient had further complications, and that led us to make a decision to transfer her to the adult services at the Royal for ongoing care. And at that stage it's very difficult because the family are then split. Their baby's in our neonatal unit, but mum has gone to the Royal for the services that were required there. But she had such complex needs that she required the care of 3 hospitals, but within a short period of time, which can be difficult for all the clinicians and all the midwives and the family to deal with. And transferring patients from different hospitals, again, very, very difficult and upsetting for the family. The women that we look after have changed. We now see women who are having pregnancies, who've got pre-existing medical conditions that they may not have been able to achieve a pregnancy previously. And that's really led us to have to develop these strong working relationships with clinicians at other trusts to make sure that we're providing the best care. But we have to factor that into our everyday clinical activity to ensure that we've got those contacts and that we're being really safe when we're providing care for the women. It's probably an added degree of pressure that we've got used to and we've normalised, but when you start to unpick it, it's probably not the right thing for us, and we could do things differently.
So Lynn and I are going to quite deliberately spend a fair bit of time this morning going through the case for change, and I wanted to start by sort of looking back a little bit at the background and how we found ourselves here today. In 2022, the NHS ICB in Cheshire and Merseyside commissioned the Liverpool Clinical Services Review, which looked at how hospitals in Liverpool could work better together to improve care and improve outcomes for patients. Resolving the challenges that face the women's hospital services in the city was one of three urgent priorities identified within the review, and the most significant clinical risk and priority for us to address. So our response to that as an ICB was to set up the Women's Services Committee, which reports into you on this board, to look at the issues. The role of the committee is to oversee the development of safe and sustainable future model of care for women's services. But it's the programme board that will develop and deliver the work that's needed to achieve this. The programme board is led by the providers in the city, the relevant providers being Alderhay, Clatterbridge, Luft, and of course Liverpool Women's Hospital. The programme board reports into the Women's Services Committee, but also into the public boards of each of our constituent providers. The programme board has led the development of the case for change by talking to the clinicians from across the city, very detailed engagement with clinicians and stakeholders to produce the document that you've got in front of you today. The draft case for change was accepted by the Women's Services Committee on the 13th of September, and it's the committee that's now recommending to the board that it approves the case for change. The programme of work is set up to look very specifically at hospital-based gynaecology and maternity services in Liverpool. This is a very specific scope that we've set for the programme of just hospital services, but that doesn't mean that we don't recognise the importance of out-of-hospital women's services, and they are being looked at. So, for example, our women's health hubs and our women's strategy is being looked at in other pieces of work. Most hospital gynaecology and maternity care that happens in Liverpool happens at Liverpool Women's Hospital, and as we've been hearing, this means it is separate from the other hospitals. That care includes tertiary care, so the very specialist end of both maternity and gynaecology services. And Liverpool is unique in this respect. It is the only place in the country where specialist and tertiary maternity and gynaecology services are delivered on a site that is not co-located with the other emergency services. So we would be talking about critical care, emergency general surgery, all the other medical specialties. Today is about process, and we are at the very beginning, and I appreciate, and I have heard that, and I have been there, I've been on this journey personally since 2014-15, so I know we have been here before, but we have gone back to the beginning of the process for this. Our first step has been to develop this case for change, which it has built on the previous case for change, which is why you will see some of the same information, because we are dealing with the same problems. But it is a much more developed case for change this time. We've got a lot more data, and we have broadened it out to think about beyond the walls of the hospital on Crown Street, to think about how we serve the women receiving services across all of our hospitals in Liverpool. As part of that process, the case for change very deliberately does not provide proposals or potential solutions. The next phase of our work is the design phase, where we will look at the clinical model of care and start to work up some options, to go through an options appraisal, and we will do that in partnership with the hospitals across the city, other stakeholders, but critically with patients and the public, and I'm going to talk a little bit about that later on. we just wanted to make the point that the vast majority of patients who use services at Liverpool Women's come from North Mersey. Predominantly that is from Liverpool, but with significant numbers coming from both Sefton and Knowsley, and that applies to both maternity and to gynaecology services. The main headlines from the Case for Change are that Liverpool Women's Hospital provides most of the care and it is geographically isolated from other hospitals. Other specialist services, other places in the country have these services co-located with them. This means the way that we set up our services means that Liverpool Women's is less able to manage acutely ill or rapidly deteriorating patients, those with complex surgical needs or those with significant other medical comorbidities, and sometimes all three. Some women fall into all three of those categories. And that is our first significant risk that we're trying to address. The acute and emergency and specialist services that those women need are located predominantly in the Royal and Aintree hospitals in the city. And that means that patients who need those services have to be transferred by ambulance, and often when they are at their most ill and at their most vulnerable. We've also talked already this morning about the fact that this means that women presenting to our other hospitals who are pregnant or who have a gynecological condition often aren't able to access the services that they need for that. We've put this into the slide pack and into the Case for Change, and it'll be part of our public-facing materials when we begin our engagement process, because we talk about Liverpool Women's Hospital being isolated from other hospital services, and people will often say, yes, but it's only a mile or it's only 4 miles. And really, when you're talking about transferring a very critically ill woman, it is not the distance that matters. It is the process of arranging that transfer, and the fact that that can often, I talk to clinicians at the Women's and they will tell me that they can spend an entire shift trying to make the arrangements to get that woman safely across to the services that she needs. And although the map shows some travel times there, those are the absolute minimum travel times. They are based on the time it takes you once you get into your car and once you get out of your car. It doesn't take into consideration the time it takes to arrange the ambulance. Or if we have clinicians travelling from one site to another site to Liverpool Women's, the time it takes them to get to their car, park their car, etc. So those are absolute minimum times. And then there is the issue that when we transfer patients, we are often taking a clinician away from what it is they were already doing, because these women have to be accompanied when we transfer them, and therefore there is impact on, often that can mean other women are impacted by having their procedures postponed or delayed. So the impact of this is on the quality of care that we are able to provide. It leads to delays in that care. It impacts on the clinical outcomes for patients, and it massively impacts on patient experience. We are increasingly aware, we've got increasing evidence of the psychological harm, and I've seen this firsthand when I speak to patients in my practice as a GP who've had an experience. Often when we're doing postnatal checks, what they want to talk about is not their own health conditions, but the traumatic experience that they had at the Women's Hospital. Particularly, I have one woman that I often think about who ended up in a different hospital. She nearly died. Her baby was in a different hospital. And that has a significant impact. I talk to the staff. You hear from the staff the stress and the moral injury that they experience by providing care in a setting that they know is not the optimum for their patients. We've got increasing evidence of the significant gender inequality that this causes. This was highlighted to us by the independent equalities review that we had done on the case for change, and it made us go away and think about this a lot more, that independent review. We do not arrange services in this way for men when, for example, if they are having surgery for cancer. Pregnancy is a protected characteristic, and yet we are not arranging services in a way that best protects this vulnerable group. They do not have access to the specialist care that other women have who have non-pregnancy related conditions, for example. And then finally, the point about inequalities, we know that in Liverpool, in Cheshire and Merseyside, we have significant issues with inequalities. And our closer look at data for this iteration of the case for change has shown us that those women who are most likely to end up with a critical care transfer or presenting at A&E in another part of the city are more likely to come from a socially deprived background and or from an ethnic minority background. So these are patients who are already experiencing inequality, and we are not arranging services in a way that meets their needs. So I'm going to hand over to Lynn, who's going to talk a little bit more about the clinical details, and then we're going to come back and talk about our engagement plans.
Thank you. Thank you, Fiona. So I'd like to continue. So we have done our best to distill the case for change down into a small number of overarching risks, and we think there are 5. The first is that acutely deteriorating patients cannot be managed on the Crown Street site reliably, which has resulted in adverse consequences and harm. Now, we're doing a lot of work in the Trust about this, and those of you who come to our board or read our board papers will see some of the improvement work that is going on at Liverpool Women's. But there are things that are really challenging for us, and we will do our best to optimise safety on site, but we feel that we cannot reliably look after our acutely deteriorating women. The second risk is about women presenting to other sites. So we've talked about A&E, but also we think about women who are on the wards at both the Royal and at Aintree. And they're being treated for things that are not related to their pregnancy or their gynecology on site, but they're not getting the holistic care that they need. So, for example, if you were to break your leg whilst pregnant, we don't have a hospital in Liverpool that can deal with that, and you'll need to be moved elsewhere. If you are on intensive care for a reason other than your pregnancy and the baby needs to be delivered so that you can be treated for whatever that is, we don't have a hospital in Liverpool that can deal with that in an optimum way. Risk 3. This is about the service specifications. So quite rightly, NHS England will define what a number of services should have in order to have the best services possible. So these are often the very specialist services, and NHS England will say you need to have these things in order to be able to deliver this service. We have a number of those services in Liverpool and at Liverpool Women's, and at Luft we have quite a lot of them. We're very proud of them. But actually we don't meet the service specifications for those on Liverpool Women's site, a number of them, because we're not co-located with a ITU, we don't have a blood transfusion laboratory on site, and we don't have other specialities on site. Then we think about the clinical service standards that we might have for services that are delivered at Luft. So I'm thinking about those specialities that might need surgery within the pelvis, so urology. Often those service specifications might say you would need to have a gynecologist. They're not there on site. So it works both ways. And we make arrangements. We have workarounds. But as NHS England is becoming more and more precise about what is required for these services, we are not meeting them. So there is a risk that we might lose them. Risk 4 is about recruitment and retention of key clinical specialities, and we've already talked about anaesthetics. And we know that anaesthetics is a hard speciality across the country. We've got lots of vacancies. But obstetric anaesthesia, which is the specialist training that individuals require to deliver maternity services, that is even harder across the country to recruit to. At Liverpool Women's, we ask our obstetric anaesthetists to do a lot of work above and beyond what other obstetric anaesthetists in other hospitals would do. So if we do have a very sick patient on site, it is our obstetric anaesthetists who step up to the plate to wrap around that woman to make sure that she has the care that she needs. We struggle to recruit to obstetric anaesthetists because they really feel this risk more than any other profession in the hospital. And then risk 5, we've already alluded to, and this is the fact that women and staff at Liverpool Women's who are delivering care are at more risk of psychological harm due to the current configuration of services. Next slide, please. So I'm going to give you some key statistics, just pulled out of the Case for Change. Over 2,000 women who are pregnant or who've had gynecological conditions are presenting at our A&Es in Liverpool. Now, we didn't know this until recently. We've got better at collecting our data, and that was quite a surprise because that is a large number. And we do not feel that those women are getting the wraparound care that they need. And a pregnant woman presenting to A&E, often one of the first questions she's going to ask is my baby okay? And we don't have the midwifery support there to give them that reassurance. From 2018 to 2022, we had 69 episodes of critical care transfers from Liverpool Women's to the Royal, plus at least another 12 who were so sick that our anaesthetist went with them on that transfer. We had just under 150 clinical incidents over a 21-month period where our clinicians who were submitting those clinical incidents felt that they were due to us being on an isolated site. We can look at our ambulance transfers, and each year there are about 220 ambulance transfers between the Women's and the Royal or Aintree that are either Category 1, which is life-threatening, I'll just pause on that, life-threatening, or Category 2, emergency transfers. So that's about half of that 220 are Category 1 or Category 2. So those are big numbers. I believe those are big numbers if we're really striving to get optimum care for our women. And because Liverpool Women's is the only tertiary and specialist provider of gynecology and maternity services in the country that is not co-located with these other services, it becomes really difficult to make comparisons. So people will say to us, well, you've only had 69 transfers to critical care. What is it like in other units? Well, it's really impossible to say because there are no other units that are in the same situation that the Women's is in. We are unique in that setting. Thank you, Fiona. So what's really driving the need for change? We know that our population at Liverpool is not the same as when the Liverpool Women's Hospital first opened in 1995. We know that we've got children who were born with serious health conditions who are growing up to be able to have children of their own. We know there are people who have serious health conditions in adulthood, women who are then able to have children. So our patient population is changing because we are now able to offer women that opportunity that might not have been offered a few years ago. And these complex health needs managed alongside their pregnancies require an increasing amount of health and support. We know our population is getting sicker. We had the Matt Ashton report about the state of Liverpool in 2040. We know that. We know that individuals are getting larger, increased rate of diabetes. We know that women are getting older as they're having babies. When the Women's first opened, about 25% of women were over 30 when they had their first child, and now it's about 50%. We know that 60% of our women who book on our maternity pathways, about 60% of those have either intermediate or intensive pathways, only 14% are eligible for delivery on our midwifery-led unit. And if we think about how the number of women on our intensive pathway has changed, we know that in 2018-2019, about 8% of our women were on that intensive pathway, whereas now that's over 12%. So our women, we know, are getting poorer. Next slide, please, Fiona. We know that demand for our gynecological services is increasing. As women are living longer, they are needing and using more gynecological services. We know that cancer rates have also been rising due to changes in lifestyle and diets, and because screening is getting better at picking up these cancers, which is great, but that also means we've got an increased demand on gynae services. And we know that the treatment of these conditions is also improving, and that's brilliant as well, isn't it? We're able to offer better treatment to our patients, and we're able to offer more complex treatments. But we know that that needs to be done in very careful coordination with people from other hospitals within Liverpool to offer that really specialist care that we want to deliver to the women of Liverpool. Next slide, please. So what are we doing now? What are we doing now to keep the women safe? And we are doing a lot of things, and we are constantly looking at what we can do to improve. How can we make things better for the women in our care? We know that if we do transfer patients via ambulance to other hospitals and these women are unwell, that we will ask our senior doctors to go with them to make sure that they are safe during that transfer. The teams at Liverpool Women's and other hospitals work really closely together to share knowledge, training and resources, and to really look at bespoke care pathways for maternity and gynecological patients with complex care needs. We now have a weekly joint operating list over at the Royal, where those patients who we've identified as being the most complex, who've got gynecology problems, can be operated in the safety of a hospital that has that wraparound care that the women need. And we know that Liverpool Women's is a maternal medicine centre, and we're really proud of that. And we have a whole suite of outpatient services that we can provide for women who are pregnant but have other health needs, so diabetes, heart problems, renal problems, haematological problems. We have a whole suite of outpatients to help support those women, and we excel in that. The challenge is if they become acutely unwell, that it becomes more difficult to manage. Next slide, please. But it isn't enough. It isn't enough as we strive to really provide the best care that we can, because staff are working hard to manage these clinical risks and to keep care safe in the short term, but we cannot resolve every risk. It's that longer term sustainability of services. And the reason that we can't do that, because the biggest safety issue is that we are not on the same site as those other services, the surgical and medical support teams that we require. And we really believe that if this is not addressed, the avoidable risk for women who require co-located services will continue to grow as those comorbidities and the complexity of cases continues to increase. We really worry that staffing will worsen and services will become harder to staff safely. The way that services are currently arranged means that some care does not meet those national standards. And if it isn't addressed, there is a real risk that we will lose those services from Liverpool, and those patients who we strive our best to provide the best possible care for will not be able to have that care delivered in Liverpool. That's already happening in certain situations. Those are not big numbers, but we already transfer some patients to Manchester. But if we are not able to meet these standards, it is likely that this will have to be more for patients for Liverpool, but wider in Cheshire and Mersey as well. Thank you, Fiona.
Thank you, Lynn. Going back now to the process, just a word on the North West Clinical Senate review, which I think was included in the pack. Clinical Senates are set up to be independent, and they bring together specialists from various different specialties, and they look at major service change proposals. So we went to the North West Clinical Senate with our case for change, and it was just worth noting, the most difficult question I got asked on that day was, why have you not sorted this out already? This is the most compelling case for change that we have ever received. It's data rich, it's well written, it's persuasive, clinical, risk focused arguments, etc. The panel also recognised, and I would like to take the opportunity to recognise the incredible work that is done by staff at Liverpool Women's currently to mitigate the risks that we have there. It is because of that incredible work that they do at the Women's that we can sit here today and say that services are safe at that hospital. But where we want to get to is a place where those risks do not exist for our women in Liverpool. So the current status of the programme, I know that we have discussed this in the past, but we have absolutely gone back to the beginning. We're setting out the key risks and challenges today in the case for change. We brought together about 70 people in May of this year, so that included clinicians, service managers and people with lived experience into an event to discuss the draft case for change, and that collective co-production approach is the one that we're going to continue using throughout this whole process. We have shared the draft case for change with partners across the city, so that will include our local authority partners, all of the hospital trusts in the city, our community services and our primary care services, our LMC, etc. The feedback on the case for change has always been similar, that the clinical arguments are really well articulated and absolutely accepted, and we've had some very supportive, constructive feedback on how we engage with the public about this when we go into the next stage. So at this stage, no proposals are being put forward for how services might look in the future, and no decisions have been made. However, it is too early, and so because of that, it's too early in the process to speculate about how services might look in the future at the Crown Street site and across the city, because we've not started that design work yet. But what we can say is that we need that hospital at Crown Street. The things that we could consider that we currently need space for would outpatients, day case procedures. We've invested in a CDC. We need that diagnostic capacity for the patients in Liverpool. And this is an excellent building to provide that from. And we are absolutely committed to NHS delivered services being delivered from that site, and there are no plans to discuss any other form of services going in there. So the next steps will be to go into a public engagement period. So assuming that you approve the case for change for us today, we're starting a 6-week period of public engagement, which we're calling Improving Hospital Gynaecology and Maternity Services in Liverpool. That will launch on the 15th of October. And what we want to do in that process is gather people's views on the case for change as we've set it out, ask them what's missing from the case for change, what have we not thought of that's important to them, what are their experiences of the care that they receive now, and what do they want in the future? What experience do they want? What services do they want? What are the things that matter? And we already know that the safe space for women and babies and the ethos of the Women's Hospital is something that the public hold very, very dear. So that is one thing that we are completely committed to maintaining and safeguarding as we go through this process. But we won't be talking to the public at this point about the proposals for the solution, which I know is really, really difficult and frustrating for people. But we need to hear what people think of how we do things now and what they want and need, so that we can factor that into our discussions. The engagement plan has been developed. We have a subgroup of the programme board called the Comms and Engagement Group, and they are working with local trusts and Thank you to our Health Watch representatives, because they're invaluable in helping us design that engagement plan. There will be online and printed material that explains the case for change. There will be a questionnaire, and we will be holding a number of engagement events. They will be both online and in person. They will be across the patch. They will be in Liverpool, Sefton and Knowsley. They will be at different times of the day, because we recognise some women work, some women have children, some women have family carer commitments. So we are going out, and we will flex that to make sure that we are reaching all the women who want, and their families, men too, who want to tell us what they think. Really important that we get hyper-local in this, so we are providing some funding to voluntary sector organisations to engage directly with specific groups. So that would speak to the very local population in Liverpool 8, some local voluntary sector organisations there will be supporting us to make sure we get engagement with the right people. All of that feedback will come into a report for us, which we'll be publishing at the beginning of next year, is the plan, 2025, and that will help inform the next stages of the programme. On that point about co-production, it is really important. I will sit here and accept and recognise that we didn't do it as well the last time as we're planning to do it this time, but I think we are learning all the time on this. We have a lived experience panel established now. I have met with them twice. That's 30 women who are either receiving care currently, have a family member who receive care. They are a wide range of ages, so they're both maternity and gynecology patients, and 30% of them are from a non-white background. So we think that we are managing to address our duties, but also our desire to engage with as broad a representation as possible. For women who can't commit that amount of time, we've got a virtual reference group and a dedicated website where members of the public can keep involved. What's going to happen next? So we're in phase 1 at the moment with the case for change. We're going into this period of public engagement. We will be starting the design work, taking on board the feedback that we get from this engagement period. And phase 2 will be the beginning, middle of next year, when we'll look in detail at the design, where we'll talk to our clinical colleagues and our lived experience panel about some potential solutions to the problem, which we will then put through a very formal options appraisal and do detailed modelling. The yellow box, autumn 2025, where we're taking stock, we will need to sit and think about all that feedback that we've got. What are the things? There might be things in there that we can do now without needing to go through any formal process, because it's a straightforward thing that isn't considered major service change. But within that, if there are proposals that are more significant, that may well have to have a business case produced and go to full public consultation, we need to take that through all of our governance processes. We'll be bringing it back to the board through the Women's Committee to make sure that we follow the process, but make sure that you are, as a board, cited and involved in the process as we go through, but most importantly, to make sure that our public and our patients are involved in that as well. Technical point on assurance for you to discharge your board duties. We have undertaken an equalities analysis, an independent review, which I mentioned earlier. We are taking this through NHS England's formal change assurance process. They have received the case and accepted and approved the case for change, which means that we can go into this next phase. We've taken it through the Clinical Senate for that independent clinical review, and the Women's Services Committee has received the draft, and the Women's Services Committee also crucially signed off our plans for engagement.
So before we go on to recommendations, let's just pause there. I'm going to seek questions and comments or clarifications from the need for clarifications from our board members. two parts. One is on the case for change, and the second part will be on the engagement proposals that are faced. So let me just take questions. Any questions on the first part? So, James, let's just carry on. So, any questions from board members on the first case? Any questions?
I'm not slandering you. You did actually say that, and you said you want it sorted within weeks rather than months. That was the 15 minutes that I got into the meeting, which was embarrassing because I've been coming for 9 years, attending online for 4 years. It was embarrassing to be thrown out. And when I said Felicity Darling was waiting to come in, I was thrown out completely. But you did actually say you weren't happy. And I would just like you to explain why and what needs tightening up, because we need to know.
Just some headlines, James.
Yeah. Very happy to answer that. At that point in time, when we were at the final stages, we'd had a conversation and we'd actually engaged with some of the colleagues at the council, and there was a view that I shared that some of the messaging within it could be quite scary to the local population, and that we needed to make sure.
We're quite good at what we do.
I don't know what that means, but the messages around clinical care. Yeah, I know. I'll see you tomorrow at the board meeting, won't we? So the conversation was we needed to make sure that the language that we used in this when we talk about risks was not going to present unnecessary concern to the population, because the last thing we wanted to do was to scare women away from coming to what we've described as a safe service now, but as long-term challenges. That's my answer. That's the truth.
Thanks.
Thank you.
I'm just seeking questions from board members. Any questions on the first part of the case? Neil?
Thank you for that, and thank you for the presentation. And I understand the emotions when you talk about any NHS change, and it's important that we hear.
Not just emotions.
I understand that. It's hear what the public have to say. For me, the case for change stacks up very clearly in terms of the safety aspect, and that's a priority for us as a board. In whatever we develop, we've got to have regard to everybody's views. We may not be able to please everybody, but we've got to come to a consensus opinion and arrive at a decision on the options that we have. So it's important that the public's views are expressed in future board reports, so they're expressed so that we understand them. Whether we agree with them or not, or whether they're mitigated by other risks, I think it's important that we all understand those aspects.
Okay.
So I'd welcome that.
We'll come on to engagement with the public in a second. I just want on clinical case for change, Naomi.
Thank you, Chair. So just, I suppose, a declaration that I have 2 children and they were both born at Liverpool Women's Hospital, and I had excellent care at Liverpool Women's Hospital. I then had, following gynaecological treatment, following complications from their delivery, and again received excellent care. A bit of background, I previously worked in the Bradford Women's Hospital, which is an independent women's hospital that is co-located with the Bradford Royal Infirmary. Shortly after having my first son, I worked at the Royal A&E department, where as a GP ST2, which is the second year of GP training, was asked to care for pregnant women who came in because I was deemed to be the most qualified in that room to look after those patients, and to then have to liaise with Liverpool Women's Hospital when they needed more specialist input. Shortly after my second child was born, I worked at Wiston Hospital, Obstetrics and Gynaecology, which is an integrated unit within that hospital. And during surgery, there was a complication where a patient required colorectal input. The colorectal surgeon was 2 rooms down performing another operation and was there within 20 minutes and was able to treat the patient appropriately. The penny then dropped at that point of what would have happened during my surgery if there had been a colorectal complication, and I asked that of the consultant there at the time. I was really shocked at the level of risk that Liverpool Women's Hospital has to deal with day in, day out. I'm a GP. I care for patients with PTSD following their complications at Liverpool Women's Hospital due to the isolated site. I also have GP trainees where, again, I have to deal with the trauma that they deal with. I am from Liverpool. I am proud of Liverpool Women's Hospital and the work it does to care for women and for babies and the work it does to mitigate the risks of being an isolated site. I am fairly sure if you look back, I have declared this to board and I've declared it to the Women's Services Committee, that my signature is probably on your list of signatures. I am one of those 75,000. The reason I signed that was because I care about the women of Liverpool and the wider community. I want to be able to be part of that process, and I want to be able to contribute to providing the best possible care for the women of Liverpool and wider areas. My question is, we've discussed the process of the case for change, and I absolutely support this case for change. But my question is, what is then the process of ensuring that the Crown Street site is retained within NHS to provide NHS services?
Okay, now let me just pause on that question. Are there any other questions on the case for change in terms of the clinical part of it? No? Okay. Graham, just respond to that last question, the question from Naomi.
I think for me, and I heard somebody also talk about their career earlier and what they'd done, but I've been a public servant for 41 years. Yeah, in that time, I absolutely believe in the public provision of services, and whilst we lead this, we have absolutely no intention of introducing any more private provision into the NHS locally. And indeed, against public policy, we are currently working on a number of instances of where we're trying to restrict the further use of private provision of NHS services. So I absolutely fundamentally believe in an NHS that is run by the NHS, staffed directly by NHS staff, and actually that includes the Crown Street site and keeping an ongoing use of Crown Street.
Okay, so let me go on to the section that's headed up next steps and public engagement. Comments from board members on, is this good enough for you at this stage? What more do we want to see? Sarah?
As most of you know, I've always been emphasising the importance of engagement and transparency on this. And again, in the spirit of Naomi's declaration, I think I'm probably also one of the signatures. When I first heard the concerns about the women's decades ago now, my thought was, my kids were born there, and you can't close that, it's a new hospital. But it's taken a long time, and lots of, to be honest, some really grim stories I've heard from patients. Some of those maternity, but also some gynae stories. People where they might not show up in those numbers, but it's had a real serious impact on either delayed cancer diagnosis, delayed treatment for cancer because they've had multiple cancers, needs for delays to get an MDT team, to get surgery on a different site, and the stresses that that's caused those women and family members has been huge. So I do have a lot of concerns about the future if we don't make changes, and I think the point of this is not what's going to happen next, because we're not at that stage, but is there something that I'm concerned enough about that I think the public need to have an opportunity to share their experiences? And I think we're at that point where I want the public to have their say. I want this information in the public domain so people can share their experiences and their thoughts about what they want for the services for the future. I've been really pleased that the comments we've made throughout on behalf of the various health watchers that have been involved about wanting co-production throughout, wanting that lived experience panel, wanting to make sure that the engagement takes place in a range of different formats and venues to give people the best opportunity to be involved. I'm really pleased that that's been taken on board. And again, just that point that when we come back with proposals, this doesn't mitigate the need to do the engagement and the consultation around the formal service changes. This is just on, we think that there may be a problem. There's lots of evidence there in the data. I think that the public need to have an opportunity at this point to give their views and experiences on that. Is that helpful?
It's really helpful, Sarah.
People are dying in
Andrew?
hospitals, in corridors, in ambulances, as we are sitting here speaking. All over the city. Because the NHS is a total mess because of NHS England, and you are towing the line. More people are going to die from PAs, anaesthetists, a baby or a child. That saddens me that she can say that and we've gone backwards.
Thank you, Chair, and thank you to Fiona and Emma and everyone who's contributed, the professionals who contributed to the Case for Change, but also those who've given their time, including the lived experience panel and those that have already inputted thoughts about the framing of the Case for Change going forward. It's quite clear today that the Women's Hospital has a very special place in the hearts of people across Liverpool. It's a site which is associated for many people with joyous moments in their life, welcoming generations of new people, citizens into Liverpool. And it's also clear that women value the specialist focus on maternity and gynecological services provided in a place that puts the interests of women and children first. And similarly, as we have also heard, the Crown Street site has a unique status within the city because of its location and its history at the heart of the Liverpool 8 community. So for those who've campaigned over many years to secure the future of the Women's Hospital, they've been voicing legitimate concerns about the future of a very valued institution, and they're rightly holding us to account for the quality of the services that are provided. The starting point for everything this board considers, and I hope the starting point for everyone in this room, is patient safety, above all considerations, and therefore welcome the extensive work that's been undertaken to analyse the risks to patient care that arise from the separation of the acute services within Liverpool. A case for change is compelling and clearly established, and action is therefore required to address those concerns. Chair, it's not generally seen as good practice to identify a compelling case for change and then take months, if not years, before that change can be put into effect. So I acknowledge that some immediate steps have been taken, and I would urge the management of Liverpool's acute services to bring forward positive options for consultation as soon as practical. And like Fiona, I want to pay tribute to the staff who work, often within very trying circumstances, to deliver the best care possible to women and to resolve and mitigate many of the risks that have been identified in the Case for Change. In the meantime, and while that process is underway, as Fiona says, there are maybe things that can be done with the more significant the more significant changes that do require consultation and scrutiny to bring forward practical changes to address the highest risks identified in the Case for Change. And on the issue of finance, NHS England and Cheshire and Merseyside ICB should be prepared to authorise additional investment if that is required to address the risks that are identified in the Case for Change. In doing so, it's important that we retain confidence amongst the public about our intentions and the intentions of the NHS. As you've made absolutely clear, and everyone around this table has made clear, this is not about closing the Crown Street site. And I welcome the commitment that Crown Street will continue to play a really vital role in the provision of NHS services. And I also welcome and endorse Graham's point about the public service nature of those services and their primary role within the public services and the public sector in providing services to the public free at the point of use. The recent £5 million investment in gynecological care at the Crown Street site also demonstrates that the health needs of women will continue to be prioritised there for the longer term. Retaining the name of the Women's Hospital within any new configuration of services is also important to the community. And as has been mentioned, there are cities across the UK where the separate identity of a women's hospital is possible within a more risk-managed configuration of services. And I would urge the NHS to come forward with proposals with that in mind. Speaking specifically on behalf of Liverpool City Council, we look forward to contributing and supporting a successful consultation process, and we will work with the NHS to make sure that all the communities of Liverpool are fully engaged in that. And we would encourage all those affected by the issues set out in the Case for Change to have their say. Thank you, Chair.
Thank you, Andrew. Ruth?
Can I? The point I actually wanted to make is actually to do with health inequalities. The Case for Change, I think, is absolutely explicit that this service supports a large proportion of the community who are disadvantaged, of challenging social circumstances, and often many women whose first language is not English. There's a huge amount of work to be done to reach that community. We need to hear from them. We need to make sure that in the engagement process that we actively seek out those women who are most disadvantaged. I speaks their language, so you're not absolutely over them, about them, and not to them. And thank you. And which is a major disaster. Exactly. I think we're in danger of agreeing with each other on that point. So what I want to emphasise is Fiona mentioned that there will be specific funding through voluntary organisations to reach those communities, and I think it's vital that we reach those communities. My wider point, if I could make it, is that there's a commitment to developing future-proofing of the services. And whilst the Case for Change sets out the issues now, I think it's absolutely vital that we take a 5, 10, 15-year horizon and in the engagement process really get to understand what women of Liverpool need for the future. And so to do that, I'd like to see a clearer emphasis through the lived experience panel and beyond that co-production will be integral to the whole process of identifying what's needed for the future. It's vital that we take this work forward in partnership with those people, women that we serve. Thank you.
Ruth. Fiona, do you just want to give a response to that last point, please?
How many of them receive money from this ICP or from the city or any of the councils, because they're not independent, nor is Healthwatch, which is funded by government. They're just levers in this to tick boxes.
Thank you, Ruth, for your question and for the comments, and I absolutely take them on board. Although we have done an equalities impact assessment at this point, we will be doing it repeatedly throughout the process. We will do it repeatedly throughout the engagement, and I'm looking at my comms team down at the bottom there, who are here today, to make sure that we are doing exactly what you've said and flexing to make sure. I think that working with the voluntary sector gives us a much better chance of doing that well. We can always do it better, so if anybody round the table has got any other suggestions, we'd really welcome them. Thank you.
Okay. Any further questions from board members before I move to the recommendations? Okay, so let's move to the recommendations. So firstly, I'm asking the board to approve the final draft Case for Change. Can I see nods around the table? Okay, so it's approved. And secondly, approve the commencement of the 6 weeks period of public engagement on the Case for Change, alongside the additions that have been talked about today, essentially about co-production and making sure we're really, really good at it. Thank you. Approved. Thank you.
What conversation did you have with them, because the NHS is in intensive...
So, I've not been... Broader question, we'll come back to it in a second. Any other business? Not been notified of anything?
Where's the equalities assessment that you referred to? Wasn't available in the PDF that I downloaded.
Okay, well, I've closed the meeting, Greg. So on that point, Fiona, I think it's is it Appendix 2?
I think it was an appendix,
yes.
But we can make sure that it's available.
Yeah. We'll get it to you, Greg. Absolutely.